It's now my privilege to again moderate the John McLean Honorary Lecture. We're changing tact here because we've just had several hours of implant surgical dentistry. We're now going back to the restorative dentistry. Now, who is John McLean? I see most of you are quite a bit younger than myself, which isn't saying a hell of a lot. And many of you probably do not know who John McLean is or was. John McLean was the first honorary member 32 years ago at the European Academy of Aesthetic Dentistry. He became a mentor to many of us. It's important that we remember, do I have this working? We don't have a remote working? Okay, I'm supposed to entertain again? Thank you, Stefano. John was the consummate clinician, of course, in the West End of London. John was a teacher, he was an academic, he was a researcher, and he loved to tell the technicians he worked with that he was a better technician than they were, actually. John has been around for, we're going to have problems with this, Stefano? Nope. Excellent. So this is who John was, and it's important for us to remember the past so we're not condemned to repeat the past, and that was one of John's favorite comments. Many of us who have been into bonding to adhesive dentistry we all remember Bonacor from 1955, etching enamel. Most of us don't realize that John McLean and Kramer published 3 years earlier about a so-called, they didn't call it the hybrid layer, but it was a hybrid layer, because they used glycerophosphoric acid, dimethacrylate, and methacrylic acid to alter the composition of the dentin, and they published that in 1952, and that was actually Severton cavity seal. So dentin adhesives are not new. The problem we had back then was the only restorative materials we had were silicate cements, gold, and amalgam. We didn't have decent polymers back then. He then also did work in the 50s on high-strength porcelains. I know these are old slides here, but this is all we had. He worked on the aluminous crowns. These are all precursors to many of the ceramics out there, the Proceras, the Dicors, for those of us who are old enough to remember that material. The two books on either side, the Science and Art of Dental Ceramics, Volume 1 and Volume 2, are still considered the Bible of dental ceramics, and it's a shame that none of us or none of the people out there who are academics and clinicians and researchers have published Volume 3, because a lot has happened since the 70s, but these are books that still are highly valued among our technical friends. Now, we've had the John McLean Honorary Lectures since 1986. There's been a whole long list of us. The most important thing, as far as I'm concerned, though, is the cooperation, the collaboration between the clinician and the technician. Technicians do not work for us. I was a technician for 3 years before I became a dentist. We work together in a team. And John, this is John on the left, that's Mick Kedge in the middle, and John Hubbard were two of his highly respected sparring partners in the laboratory. And actually, John McLean loved to kid John Hubbard that John McLean could do a better single central than John Hubbard could do. But they worked well together, and they were good friends, and they shared all the experiences together, they lectured together, they wrote papers together. We have also, with the help of the European Academy of Aesthetic Dentistry, we have founded a John McLean Fellowship under the auspices of King's College to help support young researchers at King's College. And we'd like you people to get involved in that also. Please come to the meetings and donate money, which would be great to help support the issues, the things that John McLean supported. But I've asked this year's lecturers to discuss, among other things, the new high-strength ceramics that are out there. Are they all they're cracked up to be? That's an American expression, which basically means, do they live up to their marketing hype? And which would you like to have for yourself in your mouth? One of John McLean's favorite sayings was that we would put gold into the mouths of our wives and our girlfriends and our mistresses, but we'd sell the white stuff to our patients. So this is something that has not been covered much. I haven't seen a gold inlay on the screen in I don't know how long. But I've asked our next lecturers to address which type of ceramics we should be looking at. I've also asked them to discuss the difference between indirect and direct. Should we be doing these CAD/CAM chairside? Do we need laboratory technicians? I know many laboratory technicians are afraid that things are changing. The future for them doesn't necessarily look as good as it maybe should, because please remember, we work together as a team. They don't work for us clinicians. We might have a chance to get into whether we should be cementing or bonding these various ceramic restorations. Very important question for the clinician. Hopefully we'll have a chance to go through that in the short question and answer we have left. So, with no further ado, I would very, very much like to ask to come to the podium and present 2018 John McLean Honorary Lecture, Irena and Vincent Fehmer, and I know damn well that Dr. Mack's up there looking down on you guys now. Please welcome Irena and Vincent.
Thank you very much, David.
You get a hug.
Thank you very much for this introduction and even more for inviting us to give this lecture. It is a huge excitement, I have to say. I'm very nervous. Vincent is very nervous. It is a moment in the career within the EAED of giving this lecture, which is really very special, especially after doing many years of research on ceramics at the University of Zurich and now at the University of Geneva. It's a very special moment. They gave us the lecture title also, and they called it New Challenges of Contemporary Ceramics. I, however, would have called it New Challenges of Preparing a Lecture Together like this as a team, because Vincent always said that I'm bossy, which I don't think it's not my character at all. I, on the other hand, think that technicians always know it better, so it was effectively a challenge to prepare this lecture, but I hope that we managed to show the teamwork in a very harmonious way now. So it's always like this also when we discuss cases in the clinic, it's always his fault. Well, it's normal, it's technicians. But I think we have a very special relationship to the EAED, also to the whole family that we see here, and we're very grateful that you all stayed, although it's beautiful outside and sunny and warm. It started, at least for me, after graduating at the University of Tübingen in Germany, because I wanted to come to Zurich, desperately wanted to come to Zurich, to spend some postgraduate time with a very special personality who was the clinician and the, I would say, star in the field of aesthetics, ceramics, and also co-founder of this academy. And so I had to fight a lot to get into the program, for free. And then when I got into the program, and after 1.5 years, Peter Scherer retired, I could stay on as a paid postgraduate student and then later faculty, starting to do research, because this is what Peter Scherer gave me as a legacy when he left for retirement. He gave me all the zirconia research that he had initiated at the University of Zurich, and he told me, you can take care of this. And I was stressed because I thought, well, now I have to take care of this prosthodontic research, I need support. So I called this gentleman here, who is not only very specialized in cars and very, I would say, nice cars, I must say, but also in the field of prosthodontics and aesthetics. And I said, Connie, please, can we meet? Can we have a coffee? Can you help me? And then we discussed, and I told him I need support to develop the field of prosthodontics. And then he told me, well, if you want to learn something, buy these books. And this is what I did, and I really had to grin when you showed them, Dave, because it's the same books. They're not on the market anymore. They're historic now, and I'm really, really grateful that Connie told me to buy them. And I, since ever, go back to these books again and again to prepare lectures, to learn about ceramics. So this, for me, was a very, I would say, intense relationship, specifically to this lecture today. Do you have relationships of yours that are specific, Vince?
If you look into this topic, being a dental technician, you will understand that there is only one mentor. There's several great technicians among us, but really there's one standing out, which I was following all my career, and he was like a protege for me, opening doors that I eventually had to pass through myself. But you know, the first step is always the door opener, so here I am, being very honored to say that I was like somehow, I always felt like one of his childs to follow this path, like among also, I'm sure you, Michael, and others being in this room. So at this time in my career, I was still very young, only 3 years in the training, and understood I have to improve my English if I want to be anywhere in the future. So I called Willy, and I asked him, what could I do to in a way, have my summer vacation somehow associated with learning English. And then he told me, you know, there's one person I know in London, you might want to end up spending your summer vacation, which is Mick Ketch, as you just learned from. Dave is one of the partners from McLean, working hand by hand for so many years. So that was my bond at the time with the two of them starting and getting into this field of the McLean world.
So we both had our bonds to the EAED in the end and to this McLean lecture, and that's why it was really intense to prepare it. So what did we learn from all these years and all the research that has been done? This is a case treated in 2007, a patient coming out of a pre-graduate student program, and she was finished within 1 year, receiving full rehabilitations, fixed rehabilitations with ceramics in the anterior and premolar regions and metal-based reconstructions in the posterior regions. This was a standard of care that we were teaching, that we had evaluated also, so it was evidence-based, and it was something that in a way was a daily concept of how to approach patient cases like this. She was a young patient suffering from bulimia and also a lot of tooth erosive and abrasive wear. This was the final restoration that she received. It's a beautiful restoration made by a master dental ceramist in Zurich, and it was adhesively cemented and also conventionally cemented by the dental students after or just before graduating. It's a beautiful restoration, we must say, and she's still satisfied with this restoration. She still is coming back to the recalls. But if we look at the preparations that had been performed or that had to be performed for this type of restorations, we have to say today, and it's only 10 years later, we would never again approach a case like this, like in this way, because ceramics and the evolution of ceramics has significantly changed dental medicine as we approach it now. Due to the fact that research and also clinical experience has shown that there is a lot of benefits, but there is also some shortcomings of full crown restorations, and maybe ceramic materials can help us be even less invasive and also maybe even more biologically oriented than in the past. So these two systematic reviews that we had performed in 2015 and published in 2015 were really an eye-opener after so many years of evidence-based treatment planning and patient execution. The outcomes of the single crowns out of these ceramic materials, where I would say McLean was significantly involved in most of those developments, were excellent as compared to the metal ceramic reference. The only material that was not sufficiently stable, mostly for applications in the posterior region, was feldspathic ceramic, but all the other types of ceramics, reinforced glass ceramics, oxide ceramic-based combinations like the glass-infiltrated alumina or the densely sintered oxide ceramics performed very well. So we could say, well, from a scientific point of view, evidence-based anterior regions, posterior regions, we're completely on the right track. But if we look at the biologic outcomes of all those single crowns, anterior and posterior regions, we have to say, well, maybe not. Because you see a table with a lot of numbers, you see metal ceramics as a reference, and you see the comparisons of the different ceramic crowns to the metal ceramic crowns, and the parameters that were evaluated from a biologic point of view, like caries or crowns lost due to caries. Not that of importance now. Mostly important, crowns lost due to abutment tooth fracture or loss of tooth vitality. So emotionally, we would hypothesize that now with ceramic materials, as we're much less invasive, as we're much more aesthetic and translucent, we are also biologically completely on the right track. We're better than with metal ceramics. But in fact, we found, and everything that is marked in red was significantly worse on the side of the ceramic crowns as compared to the metal ceramics. We found that it was not the case, which made us switch the concept, completely switch the concept, reevaluate the ceramic materials, reevaluate the indications once again, and develop new applications for these materials, because the application as single crown was not less invasive. I would say this is like the worst situation that you can meet. It's a patient that is 43, I would say. He's in current treatment, and he's coming back from time to time for further replacement of teeth. The etiology of this situation was amelogenesis imperfecta, so you can imagine that this patient now, at a very young age, is already in an almost terminal dental stage. Maybe because of the crowns, maybe because of the concepts, maybe because of insurances that forced the dentists to do these type of restorations, to pay for the treatments. But in the end, he received the first set of full crowns at the age of 15, then a renewal at the age of 29, and now at the age of 43, with very, I would say, good quality work. He still suffers from problems and has lost these anterior incisors in the lower jaw already. Are we less invasive with single crowns? No, we're not. And I guess some really basic studies that had nicely demonstrated these are the two of Daniel Edelhoff and John Sørensen, where they, in a very elegant way, evaluated the percentage of amount of tooth substance lost after different preparations for different types of restorations, starting from intact plastic teeth that they weighted, then they prepared them for the different types of restorations, then they measured the weight again, and with the differences in weight and a specific formula, they calculated the percentage of tooth substance that had to be eliminated for these types of restorations. And if you look at the single crown values, you see that all ceramics, despite their beauty, translucency, and maybe less invasiveness emotionally, physically, theoretically, practically, are not less invasive. And if you want to be less invasive with the same material groups, you have to switch concepts to restorations that are, and Willy Geller, I guess, was one of the pioneers of additional veneers of the edge pieces that are just replacing what we just lost and then combining this with adhesive cementation. The same also applies to the posterior region. We can see the same values, the same results, and the different alternatives from a restorative point of view that we use today to restore these teeth in order to recapture what has been lost before thinking of full crown reconstructions. Which doesn't mean that full crowns and full bridges are not indicated anymore. There's still a number of indications where we can do nothing else than that, but in all other situations, and we try to evaluate this tooth by tooth, we try to be less invasive. Which brings us, effectively, to the three main areas where, within our collaboration, maybe McLean's pioneer work has influenced our daily business. First of all, the less invasive concepts. How are we applying these materials, the ceramics, and all the opportunities that we have today? How did it influence the way we approach patients? Then the new types of restorations, monolithic reconstructions. I think the term is all over. At all conferences it's being discussed. Can we reduce the risk of problems by using ceramics monolithically, and which ceramics work well monolithically and which don't? And diagnostics, pre-treatment diagnostics, which has been influenced by technology coming up with the developments of the ceramics. So if we combine now the benefits of ceramics and the benefits of aesthetics with minimally invasiveness, we need to have a full knowledge of adhesive cementation, and we need to have prerequisites for adhesive cementation on the side of the tooth substance and of the materials. But if we do have them, it's a very, very strong tool to replace missing tooth substance without the need for geometric reduction of tooth substance in order to place conventionally cemented single crowns. So we think of classical veneers, less classical veneers, which means less preparation, even additional veneers adding to the tooth substance, almost no reduction, up to 360-degree veneers, or even palatal veneers and facial veneers as two separate veneer pieces. And we think of overlays and partial crowns in the posterior region up to occlusal veneers, tabletops, where we replace the missing enamel in the posterior region by cementing it to the existing tooth substance and not by reducing the entire tooth substance all around. So those are those new tools that are now changing, I would say, the way we approach the patient planning and the patient, I would say, analysis. So what are the treatment steps, or what are the steps that these plannings go through? The first thing we look at is what is the main problem of what is the main problem of the patient? Why did it occur? The patient comes with a problem. The patient has a certain desire, the first wish, aesthetics, or is it occlusion, is it function, is it pain maybe, to reduce the pain? But what was the main clinical problem that caused all this? What is the treatment goal? Is the next step, and this is a strong piece of collaboration between the dental technician, the patient, and the dentist, the pre-treatment diagnostics, communication of the treatment goal to the patient. How can this goal be then transferred into the clinical situation so that every tooth can be treated with least invasiveness? And then finally, adhesive cementation. Are we capable to adhesively cement? Are the prerequisites fulfilled? And can we really be sure of the goal or the success of the treatment? So let's elucidate this a little bit with a case example. It's a patient that suffered from acidic reflux for a long time, but not only acidic reflux, he also suffered from bruxism, a very, I would say, high tension personality, very kind personality, but a little bit stressed. And you can see that at one point, after having received composite restorations, filling up the dentin defects, reducing the sensitivity of his teeth, at one point, the treating dentist sent him to the university saying, I cannot do anything anymore, we need to have a full mouth rehabilitation. So with this patient now, also at a very decently young age, he has lost already a lot of tooth substance himself. His teeth are almost healthy, no caries or very little fillings. How are we going to approach this patient today? Well, if we look at the lateral views, you can see that he has lost also vertical dimension through the fact that he has lost his enamel cusps in the posterior region and also the palatal parts in the anterior region. And you can also see that a lot of tooth substance vertically has been removed, but still enamel is present. So the first analysis is, what is his problem? We had to analyze what was the cause for all of this, and then treat the bruxism problem with a Michigan splint pre-treatment, with information, with biofeedback therapy, in order to make him aware of the problem, and on the other hand, have a medical doctor involved to treat his reflux problem. The occlusal views nicely expose that still enamel is present. Some remaining composites of the previous dentists are still present but infiltrated. So in the end, he needs a full mouth rehabilitation. So how would you approach this in the laboratory now? And would you do it again like this, or would you do it differently today?
The problem is opening the vertical dimension. Doing it completely digital, what we would love to do in a daily routine today, is still very difficult. So if you have these complex reconstructions, still, if you want to achieve the highest accuracy, you want to go with a conventional face bow and then do a conventional wax up, which is very time consuming, as you can see here, but still it delivers you the highest accuracy. So still, being in the computer age, we do these steps conventional.
So you would open the vertical dimension by doing a conventional wax up. How much time does it take you to do this?
About half or even a day, maybe.
1 day. So we have 1 day. In 1 day, we have one wax-up version, so one diagnostic version, and now we have to hope when the patient comes back for try-ins that this is the right solution. And it's quite a costly situation. So you can see in his case the treatment plan was, and this is also influenced also by the spirit which is still present in Geneva with Pascal Magne and Urs Belzer, and is also followed with Francesca Vailati. We're trying to preserve tooth substance as much as possible. The concept was opening of the vertical dimension and then replacement of the missing tooth substance with restorations. So the trying of the mock-up was already very satisfying to the patient, and he wanted to proceed with this treatment. So the next step was now to transfer the opening of the vertical dimension into a try-in Michigan splint, which on the one hand he would use to get aware of his bruxism problem and also to reduce the tension in his muscles, and on the other hand to make him aware of the vertical dimension change that we foresee, and to see whether or not this would work in his clinical situation, combined with a aesthetic improvement in the anterior region. So it was a little bit of a diagnostic but also a therapeutic splint that you would do here. Could you print this type of splint, or how do you do it?
You could, but you will end up having difficulties with the combination of the two materials, because for the aesthetic zone we wanted to have something like a provisional to give him the outline of the diagnostics, how his future crowns would look like, and still we would need the stiff material to resist his bruxism in the posterior zone. So for this material combination, once again, we went the conventional workflow.
Okay, so a very conventional case. Then we received conventional eggshell provisionals, and the treatment could start. The treatment started in the maxilla because the maxilla was more important from an aesthetic point of view with respect to planes and length. And when the maxilla was fully treated, the mandible was started. So with this diagnostic, he's giving now the outline of the desired treatment outcome. The minimally invasive preparation was performed, and maybe today we wouldn't even touch the teeth. We would touch the teeth even less than now. So now a conventional impression is made. How do you proceed?
It's the Geller model, the one and only model to do in these cases, to then exchange to refractory dyes for the anterior zone. It's once again very time consuming, a lot of steps. Not only very difficult steps, it's labor hour steps, so you need really time and skilled worker for this approach, and then to end up with this alveolar ridge model that you can see here on the right-hand side.
So we see beautiful handmade work, but finally, maybe we have to discuss efficiency at a later time point. The outcome, or the final outcome in the maxilla, was feldspathic layered veneers in the anterior region, and then monolithic pressed lithium disilicate occlusal veneers in the posterior region. And you can see the pre-treatment is also differently performed with different types of acids, different concentration, different timing, and the final outcome in the maxilla. Now, an impression of the maxilla after the insertion for cross-mounting and finalization of the lower jaw. And in the end, the finalization in the lower jaw, again, following the same principles, and finally ending in these finalized reconstructions. Adhesively cemented, again with full control, moisture control, ideal preparation of the tooth substance, ideal preparation of the reconstructive material, and then step-by-step insertion of these restorations. Very time-consuming, very technically and also clinically demanding, and definitely from a point of efficiency, not a very easy treatment to do. But on the other hand, from a biological point, definitely the best that we can offer to this patient. At least this is what we feel, this is what we think. And also analyzing the literature on full crowns. Here the occlusal views of those restorations and the patient, and also the radiograph showing that now the enamel that he has lost has been sort of re-given to him by these ceramic restorations. And the final outcome after delivering of the final Michigan splint, now for a long-term, at least, preservation during the night. Those restorations are documented to a certain extent. The anterior regions are very well documented. The posterior regions, occlusal veneers, are a little bit less documented in the literature, and we can cite some of our colleagues' articles here analyzing these new types of ceramics in these types of indications and showing good outcomes on a short-term perspective, at least short to medium term. Do we have the same amount of literature as on crowns? No, we don't. Do we have the same evidence? No, we don't. But we have at least some reviews coming up on anterior restorations, because the body of evidence is a little bit larger. And this is a work just recently published by Daniel Layton from Australia, who analyzed the literature on the outcomes of 5 and 10-year outcomes of different ceramics applied for the anterior veneers. And you can see that the outcomes differ a little bit also with the type of material and technology used. But the one that is mostly used in these indications is in the range of the survival rates that conventional restorations also deliver. The biological outcomes in these studies, however, are better. The loss of vitality is lower. So at least we're doing, from a biological point, something new, or something good to the teeth. Can we do something new also with these ceramics? Well, yes, we can try to repair restorations or improve restorations, existing ceramic restorations that are not maybe aesthetically pleasing enough. Like this lady who had received this full mouth rehabilitation fixed on implants, upper and lower jaw, I would say maybe 6 months before she came to the university with the demand to redo everything, because she was lacking volume in the first quadrant. She was lacking occlusal contacts in the second and the third quadrant. And then she also complained about the color. She wanted lighter teeth. This was done by an oral design technician, so excellent work, but the patient wanted improvement. We tried to tell her the differences, either to redo the restoration or to do the alternative. So it was your idea. How did you come up with this idea?
You know, basically we were not aware about the implant system that was used. The entire reconstruction was still good, and with the few changes that we could apply, it was very cleansable. So we thought of why not just change the existing denture or like implant retained bridge that she had by placing minimal invasive reconstruction on top of it, offering it with a mock-up, a try-in that you can see here on the screen. Going beyond that point, giving the patient a visualization of it, these like small composite chips that she could wear, she could take it home along, and you really make sure that whatever changes we are going to apply to her denture, she will be happy and satisfied in the end. And as you can see her here, with the final agreement of this mock-up that we had to change and adapt once, she was really satisfied with our proposal, and thereby really limiting not only the costs, but also our, let's say, workload that we had to please that type of patient that you can see here.
So in the end, the final, oops, what happened? The final solution was that the restorations were treated like teeth would have been treated for additional veneers, slight preparation, just removal of undercuts, and the impressions were made, and finally monolithic lithium disilicate veneers were fabricated in the laboratory with conventional methods and adhesively cemented using adhesive principles on ceramics to ceramics, one by one, with a filling composite that was heated on to 60 degrees to make it more fluid. Exactly the same procedures, exactly the same concept as we would do it also on two supported restorations. And finally, step by step, improvement of an existing metal ceramic reconstruction with monolithic lithium disilicate veneers, which in the end, if we look at them, look really three-dimensional. So how do you achieve this?
By just applying a small amount of bluish, and we were not allowed to tell the patient even a little bit of sunny yellowish colors in the, let's say, more apical area of the veneer, we were really able to achieve this three-dimensional color integration here. But very clearly is one message: this only works if you are not able to fool the eye with one natural tooth in the middle. So you will have to do all of them, like all 6 or all 8 or all 10, in order to be successful with those type of monolithic reconstruction in the anterior zone.
Well, so I feel that this is in a way confusing, because now we've learned a lot about ceramics, and McLean has published a line of books that I have read and knew by heart when Connie told me to do so. And I was really, and you can see, I found it even marked in the book what I was learning most of it. It was the veneering of framework. The process of veneering of framework, which was for me is the biggest art in dental technology, which I never understood how it works. The technicians with all these differently colored powders, like pink, yellowish, greenish, finally deliver a reconstruction that looks like a natural tooth. For me, a complete arts. And all of a sudden, we are moving away from it. Can you explain it?
The problem is that you're not only moving away from it, you're moving away from your own heart, especially being a dental technician, because following Willi Geller's, let's say, legacy, it's basically that you want to learn from the best how to exactly handle this step of the process to build up the porcelain powder and to create the ceramic in a way that, you know, only a very few in this world are able and capable of. In this group of people, really, we have the luxury and the pressure of having a few of those. But as you also can understand, what we are doing is basically mixing powder with liquids and a little bit of saliva together, mixing it all up and then putting it into the frame and into the oven, and then hopefully, you know, finding the right amount of mixtures here to then, you know, create the final reconstruction that we aim for. So this case I showed you, I was lucky to show you like a few years ago in the Florence meeting, which I was very happy to share with Andrea and Fede in this stage. And we are really happy at the time to have solved this case in a, for us, new approach. As you can see here, she was treated on holiday. Within 2 weeks, she was prepped very aggressively. This was the cement gap, just, you know, to recall the case for you. And we were able to send her home with this kind of monolithic, semi-monolithic reconstructions, only buccally veneered here in the posteriors, in the anterior zone. Does it still work? Yeah, as you can see here, this part was slightly veneered, also the anterior part, and here all the other reconstructions made from lithium disilicate were just stained and glazed. Unfortunately, she had one missing premolar here, and because of all this process and all the dentistry that she had undergo until the point she got to know us, she was not willing to have one implant placed here. So since there was anyhow a preparation done, we just offered her a 4-unit bridge at the time. And at the time, for us, zirconia was a white, opaque material, not as we consider zirconia today, being more light translucent and being able to work with in a monolithic pattern. So what we ended up doing is veneering this 4-unit bridge. So this is what I could show you a few years ago in Florence. Happy patient that we sent off, and now we're here to show you what happened 7 years later. Still in the anterior buccal corridor, everything looks nice, as you can see also here in the buccal, but the moment she opens her mouth, we see on that case what we see in so many other cases. We see, hopefully you can see it also, we see 0 chippings in all the monolithic reconstructions that we did, and we see more chippings than unit in this 4-unit veneered zirconia bridge, as you can see on the right-hand side over here. So this is the daily routine, and now look at the trepanations that had been done due to the root canal treatments. Even with these thin walls that Irena ended up, no chippings in the lithium disilicate. So it's close to amazing. I don't know how it is to mill through those reconstructions, but
It is difficult, but again, it's confirming what we discussed in the beginning of this lecture. Full crown rehabilitations, they have their price, they have their risks. And one of the risks is definitely chipping, but the other is on the biological level.
yeah. And one of the risks, and now we are just referring to implant reconstruction and also to the literature based on implants, because it just gives you a higher impact value because of the biting forces, that you will see here the 5-year complication rate, which was also nicely discussed in the previous session. It's only 5 years. And if you talk to the people like Bjarni Petersson that really went into the literature delivering so many systematic reviews, you will understand that you're really smart after 5, 6, 7 years if you change your office. You go to another country, another city, and you're better off, because this is the truth. The truth is not 1 year, 2 year, or 3 years. So here we are showing you fracture of abutments are not longer an issue. Fracture of the frameworks are not longer an issue. But the biggest issue that we are facing is fracture of the veneering ceramic. 3.5% for the singles, close to 8% for the multiple reconstruction. And clearly this is associated to the way of production that we are handling here. Basically, aligning these products, the powder with the liquids, baking it into the oven, no matter how good the vacuum is, we will end up with these small air inclusions beside other factors like occlusal wear, roughnesses, parafunction, pH index, or the moisture level. We will end up with the weakness of the material and therefore with the chipping. So clearly what we could think of is just ask the industry to provide us with a very perfect dense material, and we chop it down to create our monolithic reconstruction. And how can we apply it? And this is once again a very old case. Maybe some of you have the chance to see it already. And you will see on the left-hand side that we, by the time, had the chance to do the same crown twice, unfortunately, because we had to do it again. But here we are, monolithic on the right-hand side, veneered on the left-hand side, based on the zirconia frame. On the right-hand side, you see the lithium disilicate just stained and glazed. And now for your own consideration, do you see a big difference when it comes to the aesthetic integration of these 2 reconstructions? I have a hard time, even my heart is bleeding, understanding that here I spent all my knowledge about layering techniques and all my energy about creating a nice morphology, and there I am, I have to tell you, I sleep much better with this monolithic brick here on the right-hand side. The problem, however, is that we are facing on a daily routine is that all these beautiful materials like reinforced glass ceramics, nanomaterial, hybrid materials, whatever they are called, they perfectly behave and work for the single unit replacement, single implants, onlays, overlays, whatever you can imagine. But the moment we have to take care of a 3-unit bridge or something bigger, we are stuck not being able to use these very translucent and very beautiful materials when it comes to the aesthetic integration. So dealing with this 3-unit bridge, how would we proceed?
Well, to apply the concept now clinically, let's show you an example of a case, a lady that had to have her 4-unit 2-supported bridge removed due to the very poor prognosis of the 2 abutment teeth. The plan was to virtually perform a setup of the planned reconstruction which was approved by the patient on the screen, which was then imported into guided surgery software and now helped us plan the implant placement and positioning oriented, 3D oriented to the prosthodontic outcome or the prosthodontic goal. Even the splint for the surgical guide was virtually designed, was then used in a step-by-step approach for a very, I would say, efficient and low-invasive implant surgery, replacing the 2 missing abutment teeth now with 2 implants, and at a later time, after the healing, optical impression of these 2 implants in order to deliver this information, clinical information, now virtually to the laboratory, now allowing for an introduction of the initial treatment plan, the initial setup into the existing position of the implants for final readaptation and for finalization. So when you receive the file now from the dental office, how do you proceed?
This is a very different way of receiving files now, because initially we would always start with the stone cast, with the dental model, but now here we find ourselves directly in the screen. The first contact to the case is actually designing the case, designing the morphology, in this case a monolithic reconstruction on a 3-unit bridge on 2 titanium resin bases. Here, as you can see, the monolithic contour, we try here even only with a partial scan to achieve a perfect volume, aesthetic, and also emergence profile, as you can see here. But what we also learned, that the moment we extend the single unit replacement, we have to have a model. We have to have some tool in the laboratory to really make sure that everything that we created in the virtual environment really fits to the physical environment. And we have no longer access to that plaster cast. So we need to find a way to use that data, use the model builders, print these kind of small digital models, find the analogs that are associated to this process, and thereby have the chance to create a digital master cast to work and finalize our reconstructions. Then moving forward here towards the monolithic production of this zirconia reconstruction, you see here the milling unit on the 3-dimensional 5-axis device. And then the new kind of layering that we are facing today, and it's not longer layering, this is like the pre-layering step.
It's painting Easter eggs.
It's painting or infiltrating Easter eggs, whatever you want to call it. But it helps. It helps already to individualize these either pre-colored like zirconia blanks or the complete white monochromatic blanks, as you can see here. Going beyond that point, we also learned the hard way that we are not good enough just polishing the zirconia, even if we would like to, for other reasons that we will just highlight in a few minutes. But we have to stain and glaze them in order to achieve a decent aesthetic, especially here for the posterior zone and in the buccal aspects. So the integration of this reconstruction.
So I must say that now, from a dental point of view, I receive a restoration that is more efficient, it's less costly, and still it delivers what the patient wanted. A screw-retained 4-unit reconstruction, replacing her missing teeth, in a way aesthetically pleasing, maybe not the highest aesthetics, but totally sufficient for this very kind lady who was finally very happy to have a fixed restoration, which is aesthetically integrated in a way in this dental situation that she felt comfortable with. She was really also, I would say, a fashion addict in a way, so we really liked the way she dressed, and she came with her glasses, looked like printed glasses. But there's a lot of other, I would say, factors besides the reduction of costs, which for me, for my patients, is important, that you see as an advantage with this technology.
Absolutely, because the costs clearly is one thing that we have to consider, but the quality of the reconstruction that we are able to deliver to our patients is the most important for us, because we don't want to really avoid having the patients back into our offices with all these extensive chippings that we saw in the past. But when it comes to the efficiency, just to make you aware of the changes, especially in the laboratory, which maybe most of you are not so familiar, we did quite extensive studies on that topic. Actually, it ended up to being 6 papers. And what you can see here on the left-hand side in the greenish color here is basically that the time that you will need to take a conventional or an optical impression, it's about the same. It's also shown what the time that you will need to basically cement and give away to try in the single unit reconstruction here, and also then cement the final step. And also there is hardly any difference in between receiving a conventional reconstruction from your dental technician or having computer-aided reconstruction. But the big difference that you will see is this gray bar, and that is basically what happens in the laboratory, and there is a huge change in the way that we basically work, and our routine has been driven ourselves. The laboratories of the future will have access to these new technologies. Otherwise, they just burn too much time. They don't burn the papillas, I like the word, but they burn the time in order to make all these steps handmade. The model, the wax up, the investment, all the steps that you have to carry on to come to the final step of the reconstruction.
We're also burning time. You see, Stefano is very strict.
But some of us was very long talking in the beginning. So anyway, here we are. We have the missing link, implant towards reconstruction. We cannot handle all these devices in our laboratories with our laboratories milling machine. So we need to have the missing link, and this is reflected by the tie base. And we were very irritated that there was no literature on it. So looking into this project, now finally published in the Courier 2018, we compared the complete zirconia abutments with the gold standard, which is basically the titanium abutment, and then the new type of reconstructive combination with the tie base. As you can see here, we see only complete fractures on the zirconia. Then we see the behavior of the gold standard, which is the titanium abutment. It's just bending until the screw head fractures. And then you see the same behavior on the titanium resin base with then the abutment on top of it. And this also counts up in values. You see here the zirconia abutments on the top in white, and you see then the two groups on the bottom, basically the titanium resin base with the titanium abutment. No significance in the difference between those two groups. So very promising. But those abutments is basically not what our patients are interested in. And now I have to start to speak faster. But basically, our patients are interested in the reconstruction itself, the crowns. And the crowns in these days could be monolithic, and they could be made from lithium disilicate, reinforced glass ceramic, any kind of hybrid materials, or maybe even monolithic zirconia. So how those type of reconstructions behave? Are you clicking also? Or?
No.
She's speeding me up even further.
No.
Where did it go? Here. Here you see the combination of materials after 1.2 million of chewing circles once we fracture them finally, and you see that there is a huge resistance in this material combination before they finally fracture, and here you see the ideal fracture in the screw head, and there we are with the final value. So what you see and what really was very interesting for us, even the combination of the hybrid material performed clinically very well in this in vitro study. So you see here the anemic behaved on similar values than the zirconia combination as well as the lithium disilicate combination. But now introducing these very hard materials, Irena, is that a problem for the oral cavity?
Well, it can be a problem if the monolithic materials are not high gloss polished and the surface is rough or maybe has some wear due to occlusal contacts. A number of studies have shown that this induces significant wear of antagonists, being either natural teeth or reconstructive materials. And you can see this also on the samples that we've analyzed.
Exactly. What you can see in the center is basically a conventional veneered zirconia reconstruction with glass ceramic. And on the right-hand side, you see the monolithic zirconia crown after 1.2 million circles, which basically reflects 5 years. You see this looks more or less like the Swiss Alps, and this looks like a clean mirror image, no porosities, no nothing inside. And this is the 3 study group samples that we can show you, and there you also will understand why the zirconia, even being such a hard material, when it comes to the wear pattern, behaves so well to the antagonist, because it's just perfectly with its surface. However, you see the anemic just basically degrades itself. You have a huge wear pattern here, and you see the lithium disilicate with a smaller wear pattern, but also with the lithium disilicate crystals that will give some roughness to the occlusion.
Well, the question is now, are there any limitations? It sounds like everything is possible with monolithic materials. And maybe as a scientist, I have to come back to clinical outcomes. And now, after having talked a lot about evidence, I can tell you that the evidence on everything that we've discussed in the last 15 minutes is very, very, very little. And there is not a lot of studies long-term, just one. These show good results for monolithic zirconia and lithium disilicate on implants, on teeth, but there's very, very few outcomes that have been reported. And then there is also aesthetic limitations.
Absolutely, especially speaking to people like you are, being really expert when it comes to aesthetics, and then you want to solve this case once you are back in your office, hopefully not Monday morning, but maybe next Monday, and you want to come to this final reconstruction with the distal burn papilla, right? A little bit, but you want to have this translucency in the incisal edge as the referring natural tooth. You can forget about all the monolithic talk that we just spent the last 15 minutes talking about. You want to have the veneering ceramic and the best skilled dental technician that you are so nicely working with over the past years to achieve that final reconstructions and results. The same accounts for this case. To achieve, you know, all the morphology of the surfaces, still the milling technology by itself will not offer you these details when it comes to the microtexture and the occlusion and in the surface texture. Also this one, even with the low value cases, sometimes a PFM not being outdated, not being out-fashionable anymore, can still be the best match when it comes to, Irena is really speeding me up here like crazy. Also, this is an issue that we have to deal. If you think of the first row, you can achieve decent results with monolithic reconstruction. If you are down here, based on the discolorated abutment tooth, you will understand that you need something to cover the discoloration, and the cover needs to be either a very opaque zirconia core or even a metal core, and then you need to build up your veneering ceramic. So now you are able to...
So the final, I would say, topic where the legacy of McLean and also of Scherer has influenced dentistry is communication and diagnostics. Because with all these new ceramics, a lot of new technology has come up that has now introduced us into a totally new technological world where we can try to virtualize the patients and introduce maybe extraoral and intraoral data with radiographic data to further analyze the patients. We had focused on this in the last, I would say, 5 or 6 years in a collaboration in order to find out how we can introduce the movements of faces and the expression of faces of our patients into the planning data that we already used in our daily clinical routine, the planning of implants, the planning of virtual setups. And within this collaboration, we had access to technology which was developed for the film business, which normally would not match into a dental office, we agree, but we tried to deliver the same technology with the same accuracy, more feasible, more handable for us as a dentist. And finally, the idea was to go even one step further and to try whether or not our patients could take their own pictures with a cell phone and then with an algorithm develop a three-dimensional view of themselves, send them to us for further analysis. But all of this led us finally into a research collaboration which was very fruitful. We could find out, and I think that we will jump through this because of the time, that maybe the accuracy of facial scanners is not there yet where we would like them to be, not even with this technology, because we need micrometers, we need really, really highest accuracy. But we also saw that technology could be very useful for something different than that. We could use the visualization of movements and faces in order to introduce new mock-ups into these faces and show patients what they will look like after the treatments. And in the end, ended up with the development of this augmented reality tool where we would now be able to deliver patient information via the internet in order to show patients live in their existing dentitions how they would look like after a treatment, for example, would be performed, or after the treatment that was proposed. Also delivering new communication tools with highest efficiency, because the technician would not need to spend one day on just one setup, but here we could have in 1 hour maybe 10 setups that we discussed. So finally, this is, I would say, something where our life has been significantly influenced within the communication, and also the collaboration within the team has been significantly influenced. As you can see, they start also analyzing themselves. We would like to thank all this team because they also support us with all the clinical collaborations and the science. Do you want to say something?
No.
You want to tell me, stop talking? Okay, thank you very much for your attention, and regards from Geneva.
Vincent, now you know what it's like to be in a relationship. Thank you very much to both Vincent and Irena. Why don't you take a seat over here in the middle? If you don't mind, sit on down. You've been standing up for the last hour. If there are questions, I can't see anything. If there are questions from the floor, please stand up. Can we get some microphones around here? We have one in the aisle over here. A question, please. I will. No, just a second, please.
How old is that?
Thank you, Stefano.
Quick question. How well does the stain and glaze hold up on monolithic ceramic over time? Does it wear off?
Yeah, that's a very good question, and that's exactly the weak point. You're just pointing the finger into the wound because there is really no information on this that we can at least extract out of the literature. Our experiences are not long-term experiences, so we cannot say either, but that's definitely one of the maybe worries that we have over time, that these wonderful colors that were just polished on the surface or colored on the surface will disappear over time.
One remark on this one. I think what is important is that the stain technique as such has changed. So in the past you had stains that was just the oxide, and it was basically melting to the ceramic within the glaze bake, within the final bake. Today we have a very rigid, strong material that has no thermal effect on the layer of glaze. So today, basically, the stain is a combination of glaze and stain. So you're basically applying a very little layer of ceramic. And we have like some in vitro brushing tests that show very good results when it comes to ceramics. Much worse results when it comes to the hybrid materials.
That was going to be my question, because I was very involved with Dicor back in the 80s, and the stain wore off very quickly. We had a big problem with that. We have another question? I can't see.
Thank you, Irena. Thank you, Vincent, very much for this beautiful lecture.
Here.
And if I understand well, when you have, complex case, you are still using diagnostic wax-up manually and not using any digital diagnostic tools. Does it mean that we are not yet at a level of designing that we can proceed to such cases, that we still have to go back? And if that's the case, do you think that we shortly will be able to do that digitally?
I think if I may answer first, the problem is if you work in both jaws and you open the vertical dimension digitally, it is still very complex, and you need to have very skilled, you need to have a very advanced setup as a team. Dentist, the combination towards the software, towards the technician. So this is like talking in a big auditorium. I wouldn't say this is the standard of care. So what you can do is you can, combine, you can basically take apart the upper from the lower jaw and then handle just one jaw at a time, and then you can achieve very good results in the complete digital workflow. The moment you split, you will need a digital Facebook, like a Zebra system or other system comparable to this, and even those systems where you can open the video, in the proper angulation of the jaws, are not offering you yet the highest accuracy. So we are trying a lot. We would love to have that system up and running, but we still struggle. So we were not there to this switch yet.
Connie, you had a question up there?
Could I just make a comment? Well, it seems to me that technicians are still very good to do diagnostic wax-ups, and they are used to it, especially in big cases. But when it gets to use the mouse, it's very different. And it seems to me that we need excellent technicians who know how to do wax-ups, but we also need those technicians to know how to handle the mouse very well. That's my feeling. What
Would you like?
Well, I totally agree. I think that it's like guided surgery. You cannot do guided implant placement well if you've never learned conventionally to place implants and to understand the anatomy. And I think that's the same in this field of virtual designing 3 dimensions. You need to have it done manually to have the feeling for it. Totally. There was a question. Connie wanted to say something.
I enjoyed your presentation very much, above all what you said about monolithic material. Now my question is, as clinicians, we are now faced with new generations of zirconia, with this fully stabilized zirconia, which theoretically gives us a little bit more of translucency. However, it's for us a little bit difficult to understand what can we expect in terms of long-term stability of these materials. Above all now, when we see that in 3-layer materials, fully stabilized is combined with partially stabilized materials. What do we know and what recommendations would you give us for these materials? For example, when we condition the surface, need to sandblast these materials, what are the problems and where are we going?
Well, you see, Connie, you're opening up the second wound now. The one is still bleeding that we just discussed. The point is that we are doing things in the clinics today and that we're teaching concepts today that are not fully evaluated and also, I would say, evidence-based. The point with the new types of zirconia, the cubic types of zirconia, is that their fracture toughness is lower, the stability is lower, which if you compare it to the Yttria stabilized conventional framework material that we're used to is worrying us. On the other hand, we have to think of the dimensions also. We are doing full monolithic restorations, so the dimensions of the connectors are much higher than the ones that we do in a conventional zirconia framework that has to be veneered afterwards. So we may hypothesize that this can compensate each other, but we don't know yet. There is not a lot of published literature on this, and there is not a lot of studies that are ongoing on this either. So it's an area that has to be evaluated. And patients at least need to be informed about some open questions that we may have.
And another issue regarding this question, Connie, and I think it's really, really relevant, and it's great that you brought it up, it's the lack of knowledge. For a lot of technicians, you know, zirconia, I wouldn't say is zirconia, but in the end, the blanks look very similar to each other, and the indications of those blanks are completely different. And then receiving those reconstructions, most of you being dentists, is very difficult to understand what material you just received from your dental technicians and if the indication is properly aligned to it. So that is an issue that we face today, I think.
Jaime, please.
Thank you. First of all, congratulations. It was an excellent lecture and a very challenging topic.
Thanks.
I have 2 questions. Question number 1, which is your rationale for using monolithic crowns in the anterior and the posterior versus bilayered crowns? Which would be your take-home message to all of us, the audience?
I think this is more a question that you may answer.
I mean, we try to achieve, and we think we can achieve good aesthetic results with complete monolithic reconstruction, stain and glazed in the posterior zone. For the anterior zone, we understand that the aesthetic limitation of a monolithic reconstruction, even if it's multicolor, it's not doing the job. If we are thinking of 10 veneers, of 10 crowns, and maybe we will be able to achieve a decent result with stain and glaze. But if we have to match still natural teeth in the anterior zone, we will need the veneering ceramic to achieve the perfect aesthetic outcome. And there we want to limit the amount of veneering ceramic only to a buccal cutback to have less risk of chippings.
Thank you so much. That was a very clear answer. But I have a second question. When coming back to the digital workflow, I keep hearing more and more in the last 2 years that the digital workflow can go all the way. You don't need a stone model anymore. Do you think this is marketing or is this real?
Well, marketing, yeah, exactly. For single units, possibly it's possible to work without a model, although it's not easy. For multiple unit, I would say it's impossible. Technically, it's possible, but clinically, it's a disaster.
Forget about it.
Thank you so much for sharing your knowledge with us.
Thank you, Jaime.
Thank
we
you.
have time for one short question, and a question and answer period wouldn't be good without Tidu contributing to this. Keep it short, Tidu, please.
Yeah, it's a very quick question. So with the issue of increasing the OVD and doing a digital impression and a digital bite, and you said there's a difficulty in the software. So can you not take a scan of the occlusal relationship with a Lucia jig in place to open the vertical, and then does the software allow you then to occlusally build up the posterior teeth virtually, or you still have to do a wax up to do this?
No, that would be the perfect step to do it.
But isn't that logical? I mean, why would
No,
you do it any other way?
You still missed the point that you want to do it completely digital. So you want to open the vertical dimension digital, like opening 2 models like we would have done it before. But then you are doing everything based on mean values when it comes to the articulation aspect. So you would first of all need a system to capture the actual position of the jaws in our relation.
Wouldn't it make sense then you register the occlusion in the future vertical relationship, and that's your starting point? Then you don't have any influence on the inaccuracy of the average hinge value. You would then have the actual position, and of course that's how you should start, isn't it?
Well, then you need to have had some sort of diagnostics to define the actual position.
Of course.
But this is the step that already reduces the efficiency. Ideally, you would take the impression optically, virtually open the vertical dimension, and then do the overlay design directly.
But I mean, if you went to initial provisional, then this would be your diagnostic setup,
Well,
right?
yes.
Yeah.
In
And
this
you,
case,
in a
but
case
this was
like
a
this, in a case like this, would you ever go straight to a final? No, it's not sensible. You would always want to do some kind of test drive.
Well, in his case, definitely. He was also playing the trumpet, which was another challenge that we didn't mention, because
So it makes sense to start with composite rather than go to ceramics, and then maybe consider ceramics longer term.
Then you have a double scan and you are perfect with the occlusion. That works perfect, but this is not a message that you have a clear workflow that offers you from A to Z, and here you are.
But I think the point is your case, it should not be the message that you're sending that such a case should be finished in one clear workflow. You should have always a provisional test drive in these cases, and then go to your definitive once you've had a chance to verify this is working.
Tina, I'm going to interrupt here. I suggest that you take breakfast tomorrow morning with Irena and Vincent and deal with it over breakfast. My president, our president, has approved one more question up there somewhere. I can't see anything.
Yes, I would like to thank you for a very nice and very balanced lecture. My question is about invasiveness, and I think it's related to Irena Saylor. We know that metal ceramics is invasive. What about today's high-strength zirconia CAD/CAM ceramics? How would you say about those?
Well, I would say that the material thickness requirements are not much different from the ones of metal ceramics. So we have a universal tooth preparation in the end with a 1 millimeter shoulder margin, and then the conventional reductions in the axial and the incisal areas for all ceramic as well as for metal ceramic reconstructions. The material dimensions are not much different. And in the end, the clinical data in the review showed that the outcomes are also not much different, so not favoring all ceramic reconstructions from a biological point of view. So in the end, it's, I would say, on a single crown basis, you can select out of all the available material options from an aesthetic point of view, or with aesthetic goals, but in the end, biologically, you're doing, I would say, the same to the tooth.
Thank you.
You're welcome.
Before Christian runs up the stairs there, I think it's important to know that Irena showed the books, I showed the book, The Science and Art of Dental Ceramics, Volume 1, I believe, is still available in digital format from Quintessence, is it not? It is. They haven't done Volume 2, but you can get it digitally.
Good.
I'd like to take this opportunity to thank Vincent and Irena for embodying the spirit of John McLean. There's no doubt about it. He would have been very proud to have had you up here to be his honorary lecturers. It shows the importance of having a relationship with your technician and clinician. But we do know who the boss is. Thank you very much. Please thank him for this.